a 3-year-old male came with complaint of pain in right flank pain since 3 to 4 months and associated with difficulty to pass urine since 2 months. Okay, we'll move to the elaboration of the history. Pain was dilating in nature, incidence in onset, mild to moderate, no radiation, no aggravating and relieving factors. There was difficulty in passing urine since 2 months, associated with straining, scanty void, and increased frequency and urgency. And there was no history of incontinence, burning micturition, hematuria, pyuria, or fever. You want more history?
Whose case is this?
Yes. Sir, I have given the case myself, sir. I should have elaborated the history related to the lower urinary tract symptoms. The patient has got straining with scanty void. So the amount of urinary void per void and the frequency and daytime frequency, whatever that has to be highlighted in details.
This is your case, no?
Yes, sir.
So one of here people will discuss. Anyhow, you cannot be presenting and discussing yourself. Okay, you discuss now.
Yes.
So what do you think now? Differentials. I think that's all the history, unless you have any treatment history.
No treatment.
Yeah. Before we go there, what do you think? Child, 5 to 6 months, history of flank pain and difficulty in passing urine.
It can peri-ureteric obstructions.
But why they will have difficulty to pass urine?
Some prototype obstruction can be posterior wall.
So you mean to say last 2.5 years the child had no posterior valve, suddenly there became a posterior valve at the end of 2.5 years?
Can be associated with the VUJ calculus or bladder calculus.
How common is VUJ calculus or bladder calculus? So what, think positively or what is likely differentials? You can say, think logically, what's the possibilities? Viewer should cause flank pain.
Congenital?
Yeah, some congenital condition.
Yes,
what it can be?
Primary obstructive mega ureters.
With the additional UTI, but of course there is no fever, it's not fitting in. But again, primary obstructive mega, why it should cause difficulty in passing urine? One is UTI, great. Otherwise, it should not cause any. Phimosis at last 2.5 years, no issue. Suddenly, why it should? Possible if there is some tear in the prepuce and all that. But flank pain is not explained by phimosis. That's not possible. Okay. So congenital, you have told PUJ, mega ureter. Okay, then
Posterior valve.
Late presentations are possible, but why it should no, look at this. The child had flank pain first, and then the child had lower tract symptoms. So in PU, it should be the other way. Very unlikely to have flank pain in PU. Remember, unless there is some additional complications, a UTI or something like that. Okay, very unlikely. Child with PUV usually diagnosed a little earlier, though delayed presentations are now. Okay, PUV will yeah, mega ureter obstructive, then ureterocele, fine. What else? You are told congenital conditions. Anything else? And the other thing is, viewer with the pyelonephritis, but 6 months history is very unlikely. Okay, anything else?
So separate conditions like conditions related to the kidney and
What is
lower
that?
tract. Separate conditions, unrelated conditions leading to
A particular condition may be complicated with. You cannot put separate condition. More separate you put, more unlikely it is unlikely.
Okay, sir.
Yeah? So you think logically. You may get out of the box some diagnosis. What malignancies you can think? Wilms tumor. Okay. That's not okay.
PUC also leading to flank pain.
Flank pain with UTI. Otherwise, the child. Why should the PUJ child have difficulty in passing you?
Yes.
So you have some congenital, infective, and neoplastic conditions in mind so far, right?
Yes.
Okay. So if you are thinking of infective, what questions you'll ask? If you think of neoplastic, what you want to ask? Especially in children, you should ask more details. The mother can tell you everything without seeing the child. I mean, you not seeing the child, you can get that information. What's happening?
Change in the feeding.
Feeding habit, growth habits, everything.
While widening,
That can be due to stone also, but I'm just telling. So, whether this in any child history, if you don't ask about growth, appetite, irritability, bowel disturbance, all those things are not mentioned here. Whether it is gaining weight over a period of time or losing weight, appetite has dropped down, everything the mother will tell. Whether his frequency has increased or she will tell what was the number of diapers he was changing, and now you can ask in many different ways. Is he having bladder control, bowel control? It's not the same way you take a history in an adult. You should change. If you want, you can ask, start from, did you get antenatal scans? Did you, was he vaccinated? Everything. The history in children starts differently compared to an adult. Anyway, we go ahead. No. See here, I would ask you, so last 6 months and 2 months, whatever this pain, what treatment has been given? You think the mother would have kept quiet? And how severe is the pain? Did the child have vomiting? Did the child have required injections, admissions? So treatment part of the history is completely missed. Any parent will not wait for 6 months if the child has flank pain or a difficulty in urine. Unless you want to keep it for the later part of the slides. But usually...
no, sir, no specific treatment history was there. They had just gone for the primary evaluation, and immediately on some ultrasound finding, they came here for treatment, sir.
Right.
So they are...
The clinical examination is unremarkable since there is no palpable mass in the left flank region.
Left or right? Okay, anyway.
So, 3 years. Yeah, 144.
Okay, anyway. So nothing, examination. Of course, phimosis is also not mentioned, which is probably physiological. Again, weight is not mentioned. No, see, the earlier Campbell, that's about 10 years back, used to say up to 2 years is physiological. Now it is 4 years. Up to 4 years is physiological.
Up to 4 years?
The prepuce,
Physiological up to 5 years.
yes, prepuce may not be retractable, and we should not do forceful retraction.
Okay, sir.
So,
Right.
I have to know urine analysis and basic blood restriction with complete blood count.
Okay, proceed. So we have, bowel history, treatment history, vaccination history, all those things are not there. We assume it is normal. And weight is not mentioned, height is not mentioned, growth chart is not there.
Okay.
See, in the exam, all those things will be kept by the side. I mean, if you want, you can always, you cannot even, when the examiner asks you, so did you check his weight? You cannot say, I didn't know. Because
I
they
forgot
will
to
show you, it is all available.
Weight of the child was 11 kgs, sir. I forgot to mention it in the slide.
Is it appropriate? What was the child's birth weight? How do you calculate the birth, the present weight compared to the birth weight? What should be the weight of this child? Suddenly appropriate.
Becomes double by 1 year, double by 5 months, triple by 1 year.
No. 5 months is double. 2 years it is 3 times. So what was the birth weight? We don't know. Anyhow, we will. We don't have the details. We will proceed. Urine. Okay.
So blood investigation and urine.
Comment. Don't.
Normal, sir.
No, HB is little lower side.
Hemoglobin is on the lower side.
Should be around 14 at this age. But little low. Okay.
Urine analysis is normal, sir.
Right. Culture no growth. So one possibility we had is infective conditions. Little unlikely. So we have still congenital conditions and malignancy as the differential.
Yes.
Okay. Next, what do you want to do?
Sir, I want to know ultrasound to see the upper tract changes or.
So why did we get RBS? No? Random blood sugar.
Yes.
Thinking of diabetes at this age?
No, sir, just as a part of the routine preliminary investigations, screenings. Yes,
what would have been more important would be albumin or something, which will, you should keep in mind what you are thinking and appropriately get it. So one is albumin, that will tell us the nutritional part of the child.
Okay.
One is hemoglobin is definitely low. If albumin is also low, that means the child is in a catabolic phase. Something is going wrong. Okay, anyway. Next.
I want to know ultrasound.
Next. Okay. See, again and again we have told you, if the ultrasound is of very important, significant, then you make it single image. Make it single image, it will look better. Anyway, doesn't matter.
Okay.
Proceed. No, just describe the findings.
Sir, the images so on the top.
This fellow will describe here. Okay. Yeah, this is right. The left bottom.
Right.
Left kidney.
Upper two images of the right kidney, which shows a significant dilatation of the collecting system and thinning in towards the upper pole. There is a dilated collecting system towards the upper pole with normal appearance of kidney towards the lower pole. And
see, I know anybody can tell this is hydronephrosis, but what I'm asking is what is striking in this compared to any other? If I want to label this as PUJ, what is not fitting in?
LVL is not dilated, and it's only calyxes are dilated in ureters.
Okay.
Ureter
Not
not
the
same.
same.
It's left kidney here.
the entire collecting system is not uniformly dilated.
Ureter is the PUJ is down there. Down. No, the PUJ, I think the PUJ is somewhere here or it is here. Maybe here, I would say. Because you see, everything is joining here. This is also one of the calyx. This is joining here. You cannot have a ureter going there. This one.
Ureter. That to be calyx, that 1 million calyx.
likely to be ureter. And ultrasound is usually operator dependent, depends on what you need. Here also you see, this also, you look at the calyces are on top of all of this, and it is coming. So more, this is more likely rather than this. Then you may think this is the pelvis. No, this is the pelvis. Because all are joining here. Then it is going there. Okay, so what all you are told? You unequal delta or you
PUG I told, sir. And then ureterocele.
No, I'm talking of this finding.
Findings are the calyces are dilated, pelvis are dilated in this case, and ureter.
They might have not shown it appropriately, but anyhow, we'll go by whatever is shown. The dilatation of the calyces are more. The APD, if it is measured, fine. Then what about the kidney part?
It's a cortex thinning is parenchymal thinning.
So whenever you say you have to mention the size of the kidney, the parenchymal thickness, the corticomedullary differentiation, and compare it with the opposite side. You can say it's thinning or normal compared to the opposite side. So in a PUJ, the kidney, what will happen to the size of the kidney?
Increase, size will increase, sir.
Okay. In a classical VUR,
Shrinks.
when chronic pyelonephritis sets in, the kidney will be relatively smaller. So by size of the kidney, the PUJ will be usually a larger kidney. Again, you can have all types of exceptions. And the opposite kidney, if it is enlarged, that means this kidney function might have been compromised. It is already compensatory hypertrophy can also be there. Okay, then
Now the PUG is showing there is no pelvic dilatation.
left kidney is normal in size, location, position, corticomedullary differentiation. There is no hydronephrosis. You should start like that. Left kidney normal, no. Normal in size, position, location, whatever. You speak like that. Okay. So fine, we'll see other images. What is this? What is here also?
The bulging mass is in
Mass, where is the mass?
Is there, but the ureter is dilated.
Show me. There's no ureter there. It is the bladder and below that what? It is the bladder, neck and prostatic ureter. Ureter. Okay, right.
And bladder wall thickening is also.
That is prostate they mentioned, I think. Okay, fine. Anyhow, what basically we were trying to explain is this is something looks like a keyhole sign in PUV, but can I put this as the PUV? Very unlikely. Why? One is
No bilateral hydroureterocele.
yeah, one is thickened bladder wall is not there. Two, they're usually associated with bilateral hydroureterocele. Here it is not looking that way. But again, exceptions are always possible, but this is classically not fitting. Okay. Let's see the report. Okay, so what do you want to do?
Sir, MCU.
Why you want MCU? So what are the possibilities looking at the ultrasound?
Ureterocele, sir, now. And
Ureterocele. After seeing the ultrasound, let's say it has been done properly, and ureterocele should have given some finding, no? In the bladder.
So look at the
I
finding.
can put my diagnosis.
Somebody is telling. Oh, yeah, Dr. Manish?
Look at the findings in the right kidney carefully and see if on the basis of this ultrasound you want to revise your diagnosis.
Sir, first differential diagnosis will be
You tell, yeah, okay.
pelvic junction obstruction, sir.
So why there will be upper ureteric dilatation in a PUJ?
can be upper ureteric stone also.
Very good. So you simply, it can be anything. So
Which congenital condition will cause right hypernephrosis and right upper ureteric?
Ureter, sir.
Yeah, so keep thinking about what are the possibilities and then say stone is very unlikely.
At this stage, why you want? Okay, please.
Yeah.
No, at this age, stone you should not put as the first diagnosis. Okay. So one is retrocale, one it can be low-lying PUJ. Is it possible? Yes. Okay. Then
Can be VR.
PUR you should get ureter is usually more dilated than the upper ureter. Again, possible, no problem. Sometimes you cannot identify properly, but low ureter you should be able to. Again, it depends on the person who is doing it. But let's say it has been done by an appropriate, experienced person. Anyway, so what else? Okay, I think that's it. Fine. Next, what do you want to do?
So functional study I want to do AC renogram.
You want to see executive?
Is your imaging complete?
Yeah.
You want to do a functional study? Is your imaging complete?
No, sir. Still, MCU we can proceed, sir, before going for
What are the two approaches? Two kinds of approaches used in evaluating a dilated ureter.
So lower track we have to evaluate first, sir, and then upper track.
No, what are the approaches? Imaging approaches.
Sir, this MCU we can do, sir, first.
It's referred to as what? To something to top to bottom, bottom to top, something like that. There is a bottoms up approach and there is a top down approach. These are the two approaches. What is the top down approach?
Sir, CT IV urography we can do, sir.
What is the approach? What do you gain by a top down approach? And what are the shortcomings of the top down approach?
One is not heard of top-down approach.
Okay.
Move on. The top-down
First, we have to do, sir, a functional scanning in top-down approach to decrease the radiation.
The top-down approach is evaluation of upper tract first, followed by lower tract evaluation, sir.
What is the logic?
Yeah, it is classically in VUR. The debate is in VUR. In VUR, will you do a MCU first or a DMSU? So if you top down means you do DMSU first and then you think about MCU. Bottom up is first you do MCU and then you think of DMSU. So in this case, which one you would like to do? You want to do a CT first or you want to do a MCU first?
So CT first, sir.
Why?
It's only there is no changes in the bladder and only upper tract changes are there, sir.
See, when you discuss a case, you should know about the history of the case also. Did this child have only flat pain?
Lower tract symptoms also there.
What is not fitting in here is though the child has lower tract changes, the urine is normal.
Normal.
UTI related.
Yes.
It is not matching. The child is having lower tract symptoms. But always keep the background of the case in the mind. Just because you saw an ultrasound, don't jump into further imaging. Keep everything in mind. You are treating a child. So you should be very, very careful about exposing the child to unnecessary radiation also. Can you get that information by any other imaging? It has lesser radiation, then you may prefer it compared to an adult. In adult with the same finding, I would agree 100% with no choice to jump to a CT. But here you have to value your study, whether you want to do a CT or EC renogram. Anyway, we will proceed with the
This case is from who? Yes.
Next.
You had one differential of retrocavalic ureter. What is the finding you will get it in retrocavalic?
Reverse Jason, sir.
Any other better terms used? It's not called reverse J.
Stick. Shepherd's stick.
What? Okay.
You said reverse J. These are all classical IVU signs which are described, so you cannot forget this. Fish hook thigh. Okay, what do you see here?
Dilated ureter.
The animal is the animal which looks exactly like the retrocavalic. Yeah, seahorse. Seahorse. The fish hooking is for the lower end of ureter and BPH. Classical. I think the terms are not to be that but you get the picture in your mind.
Yeah. Please.
The left kidney is a normal size and shape, and there is normal contrast uptake and excretions around left side. Right side also there is a normal uptake and excretion, but ureter is a dilated hole along the length side. And there is mass protruding into the bladder.
Oh, what are you using? Man? Use proper terms. Mass. Huh? If you use some loose terms, you are in deep trouble. No? Did you see a mass somewhere?
No, sir. Cystic cavity, cystic structure protruding into the bladder, sir.
Cystic structure. That means you are talking about the ureterocele.
Yes.
Huh?
Yes.
Where did you see?
Here, down.
You don't comment on reconstructive image. Do you see any cystic structure?
No, that one last image. No, here I did not visualize.
You please look at the cross section and comment.
Okay. Delayed phase in the bladder section.
So delayed section you will get ureterocele if it is there, or which section, which part of the, if you are looking for a ureterocele, which part you will, in the bladder filling, let's say I am filling it slowly.
Initial part of bladder.
You will see it when it is less filled.
Less filled.
When it is over distended, it may get
obscurity, everything same. Isolated.
So don't, so this is probably not fully distended, or it is distended, I would say. But anyhow, you are not seeing any mass.
Yes.
In that last image, based on that one, this is the last image.
The reconstructed image is not the image based on which you will accurate. The radiographer who is doing all that. Scanning the images.
The next one image, sir, that there is no contrast uptake in the upper calyx there.
So what do you see here? Very good, very good. What is this? Don't make your decisions based on one particular image. Are you seeing that here?
That is pelviuretic junction.
This one.
Upper pole calyx.
What is this and what is this? It's the same.
Pole calyx are
So
relatively less dilated.
now you are commenting on one particular image. Now, so this there is no calyx here.
Delayed image.
It is because you are taking coronal sections like this. The kidney part is not visual, it is coming down. So again, always look at the cross-section images. Are you seeing the good function here?
Yes, sir.
So you know this is a good function. Just don't look at the longitudinal section and jump on it saying something.
And also this lower pole is not much dilated compared to upper pole.
So I would ask you this way: if a case of obstruction in the lower end, does that difference make? The entire kidney will be dilated, or only
If there is a duplex system, it can be possible.
Is there any indication for you to think this is a duplicated system?
Yes, sir. This this portion contrast is showing, but this lower portion is not showing here. Is here contrast is going here, sir, but contrast is not going here.
Two separate.
So, duplex system can be here, sir.
Ureter is other ureter.
Visible only. There are also differentiation.
Whether you are saying, see, the dilatation was uniform, it is only the. I don't think it is duplicated system, but you can only adjust. But look at the cross section. Cross section, the dilatation is it's not marked here. So you can see this dilatation.
Yes.
Lower pole there is third image.
It is already uniform.
Very LPs here.
The child have UTI?
Sir, no, sir.
Culture negative.
Culture negative. Sir, but this reconstructed image of the cystic structure is not visible in other images.
There is no cystic structure, man. If it is a primary obstructive megaureter, where is the cystic structure? If you see, yes. Don't decide based on reconstructed image. There was nothing to indicate in the ultrasound. There is nothing to indicate in CT films. Then why should you want to set as that? So looking at this, whether it is a duplicated system or it is a single system, there's definitely a megaureter, obstructive megaureter.
It can be this duplex system, sir, with double ureter, means incomplete duplication, and it can be this one, primary obstructive megaureter.
So, if you want to diagnose obstructive or influencing, what test you need?
MCU easy enough.
Proper easy renogram will do this.
One confusion.
Contrast now. Why you want another easy renogram?
Obstruction. We can take a delayed film.
You want to say this is a reflux or no?
MCU can do yes.
We have a debate about whether it is a duplicated system versus a single system. If you are assuming that the lower pole has a separate ureter, it should be demonstrated, but it is not seen anywhere. No, it is not shown. And it is also dilated.
Here one portion.
No, it is also down one. Yeah, you see, this is either it is interpolar or whatever, but everything is dilated. So,
Prabhu, if you look at the middle image is the extreme right, the so-called reconstructed image, the ureter. Yeah, exactly. We just go down that arrow. There is a small little area of contrast which seems to be coming out. Just move that. No, there's on the ureter. Go up some more. Go up on the ureter. Go up. Stop. Yes. Now, I don't think we can ignore that. If it was a dilated ureter, if it was tortuous, then you'd see it. It's a dilated ureter. We are trying to explain whether that blotch of contrast in the lower pole is part of a bifid system. Is it a duplicated system? So the question that Dr. Prabhu asked is, you have to decide whether this is a duplicated system at all or not. If you look at a duplicated system, the first thing is the kidney is enlarged in a duplicated system. Secondly, if there's a duplicated system, then the collecting system in the upper pole will not be shaped like this. You see, this may be representing a bifid pelvis. You know, the little bit coming off from there which we are not seeing, and the rest of it is a dilated ureter. At the moment, to me, this looks like a single moiety with a primary obstructive megaureter. It's a pity they missed it on the ultrasound. Sometime back, there was a discussion about radiation for children. In fact, most of the times you can get away with sonography and an isotope in children. One rarely uses these except when you're looking for duplicated system and all that. But you know, nowadays with MRI, they are able to do most of these things. So, yeah, I guess that this is an issue here. So I think we'll have to look at that point. I don't know whether that is something that I'm not willing to ignore at the moment, just on that reconstructed image, trying to explain that blotch of contrast. That's what
Only when I saw it, I thought there was a separate lower pole moiety with the ureters fusing somewhere in the lumbar region. What you pointed out, you know, in the third frame in the middle row.
Yes, that's the only one that's showing it, you know.
Yes, you know, it looks like a Y-shaped.
Maybe, I don't know.
Because in the very first film, first and second films, when we look, the contrast uptake of the lower portion is happening much earlier than in the upper portion.
Yes, it's a much better functioning segment. Very good.
Yes, it's
Double along there.
double ureters along the.
Ureterocele, they said.
If you tell the answers without the images, that means you know the case.
No, sir, that cystic structure is there, sir.
We could see it, only you are seeing it, somebody has told you. Or you have gone through the slide sheet.
But whatever it is, this report does not match the CT findings.
In one of the cross-sectional images, sir, we can see the right lower ureter ending in the endovagus, and there is a dilated portion.
Third image, upper.
Third and fourth image, sir.
If it was, why did they miss it? How did they miss this on an ultrasound? Is my question.
The ultrasound is also showing the dilated right ureter, so that they have not commented in the bladder section.
Let him discuss, Praveen. Keep saying, let one person discuss and then you can move on to others. You looked at the bladder sections. Who's discussing?
Sambhaji, sir.
Sambhaji?
Yes, sir.
What is it that strikes you when you look at this bladder? The first image.
Sir. That near the right posterolateral wall of the bladder.
At a gross viewing, let's go to details later. What is it that strikes you?
In lower portion of the ureter is dilated, sir.
Crossly the bladder.
The bladder itself is inadequately filled, isn't it?
Yes.
Because the shape is not of a full bladder. The subsequent sections which have been taken, unfortunately, I have not looked at this in a distended bladder. On a modestly distended bladder, you can make out that cystic structure of the ureterocele. But if the bladder is collapsed or if it is over distended, it's possible the ureterocele gets obscured. Okay. Yes, let's proceed. Let's move on. Why do you think the bladder is thickened?
Sir, it can be associated with again posterior urethral walls. We have to rule out, sir.
Oh my God.
Anything to suggest posterior urethral valve on the ultrasound or on the CT?
No, sir.
Nothing. So leave that out of your equation.
Don't put total diagnosis the possibility. We are getting it very, very, very rare. How many cases you have seen where you have a primary and a PU?
It's bladder wall is thickened.
So bladder wall thickened is PU.
No, it's outflow tract obstruction.
What else? See, you have a dilated ureter. you have a thickened bladder wall, and on ultrasound, it appears the bladder is not filling completely. Or at least when they did the ultrasound, it was not. Can you put these three together and come at a reasonable estimate of what the pathology could be?
How old is it? 3 years.
It's primary obstructive megaureter with.
Why will the bladder be dilated? Why the bladder be thickened? Bladder won't be thickened. See, for a bladder to be thickened, there are certain distinct conditions. One, the bladder is working against resistance. The bladder has more work to do than usual. Two, there is an infiltration of whatever kind into the bladder wall causing the thickening. Right? Now, can you think of conditions where the bladder has to do more work than usual? Any non-obstructive condition where that happens? Obstruction we know. There will be thickening.
Dysfunctional one.
Bowel bladder dysfunction.
Functional obstruction. Praveen, let him answer. Praveen, please.
Sir, bowel bladder dysfunction, constipation associated.
See, all of them will present with difficulty in voiding urine.
He is having voiding difficulties.
He is having voiding difficulty.
Yes,
What
sir.
exactly is the voiding difficulty?
Straining to void, sir.
He has to stray into void. Okay. So think of other things, fine. If you want to consider.
What is the common condition where it is not obstructed but the bladder wall is thickened? Very common condition. Patients present with a triad of symptoms usually. The bladder is not obstructed, but the bladder wall is thickened.
Associated urine tract infection.
A condition which is very common in women.
Associated urine tract infection, sir.
No.
This type.
We're talking of non-infective, non-obstructive conditions where the bladder can be thickened in association with a dilated ureter.
Neurogenic bladder, sir.
Why should the ureter be dilated? Common, you see, when you look at everything, neurovesical dysfunction, which is the correct term to use, is not very common. And there is usually a history of either trauma or of associated neurological deficits in children. Something fairly common. One of the things we would look for if somebody came with recurrent urinary tract infection, especially girls.
Does the patient have to do extra work because more urine is coming from somewhere else? Every time the child passes urine or something. More work, but not actually obstructed, ureter is dilated.
Reflux.
Huh?
Constipation.
Reflux with pseudo residue, sir.
Reflux. High-grade VUR can produce this because the bladder is working, then it goes up, it comes down, again it's working. So, there's not really an obstruction there, but just overwork. Can you think of another condition where the bladder is thick-walled, but there is no obstruction and there is no ureteric dilatation? No ureteric dilatation, bladder can be mildly thick-walled like what is described here, but there is no obstruction. Another common condition. We see it in the OPD and all that. Very.
Overactive bladder.
Yeah, overactive bladder. Yeah. Overactive bladder is not obstructed, but the bladder wall is thickened because of overactivity. So there are situations where the bladder can be thickened. But in this child, they said the question that was asked by Mohan was, why is the bladder wall thickened here? This child present with UTI, no?
Yes.
No, sir, culture is negative. And
The child present with UTI.
the child has only flank pain and lower tract symptoms from 2 months.
Okay.
One other reason is the bladder is partially distended and there are many sonologists who reported
Yes.
that thick wall.
Correct.
If don't jump into it. And to do a pediatric scan, you need a relatively experienced sonologist. A person who is doing rarely a pediatric will not be able to pick up all the findings. So this was
How old
the
is
case.
this child?
3 years.
3 years. 3 years, okay. You see, first thing you look at when they say bladder is thickened is whether the bladder has got enough urine in it or not. If it appears that the bladder is not filled adequately, you can't go by the thickening. The second thing you look at when there is adequate distension and thickening of the bladder wall is whether one or both ureters show dilatation. The third thing that you look at is whether there is a residue. The fourth thing that you will look at, if you get answers in the first 3 questions, is whether there is an increase in ureteric and calyceal dilatation after voiding. Okay, so ultrasound has to be tailored. It's not something which is done once and then you send the patient away. You may not do all this in adults, but in children it's quite useful because it doesn't involve radiation. All other investigations involve radiation or an invasive procedure.
So, Sambaji, are you happy with the diagnosis so far, taking the clinical picture in place, or you want still more imaging or tests to be done?
Oh, sir, based on this report, I want to
I told everything. Taking the clinical picture and the report so far, are you happy? Or you want to proceed with the treatment part, or you want to still continue
and to proceed with treatment first.
Okay.
What are you going to treat?
Cystocele, this ureterocele.
How do you know it is there?
Sir, we can do cystoscopy and proceed, sir.
Patient develops UTI after cystoscopy, you don't see anything inside. Child has already had UTI. See,
no UTIs.
The algorithm, we've been repeatedly saying, child has flank pain fever. See, we've been discussing this. Before doing anything invasive, we should see whether non-invasive options are available for arriving at a diagnosis. After we finish the entire list of relevant non-invasive investigations, we start doing invasive things, right? So
we can look for lower tracts now. For MCU, we can proceed, sir.
You want to do an MCU? Will that show ureterocele?
Not sure.
May or may not. Right, depending on the filling.
How will you tailor the
What is your diagnosis here?
Primary obstructive megaureter, sir.
Will an MCU help if the ureter is obstructed?
Is it the complete diagnosis what you told?
In the presence of a ureter, which is dilated right down to its termination, the alternatives we have is that it's a primary obstructive megaureter or it is a refluxing ureter. Of these two, which one can you pick up on MCU?
Primary obstructive, reflux.
Reflux you can pick up.
Yes.
Which is more common, obstructive megaureter or reflux?
Reflux is more common, sir.
Reflux is more common. Which is what, that's how you will justify your MCU. Otherwise, people will say ureter is dilated, why do you want to do an MCU? Supposing we put it to you that instead of doing an MCU, please go ahead and do a rhinogram. What measures will you take while doing the rhinogram?
Sir, we have to polycatheterization to be done for child before doing.
A polycatheter in a 3-year-old for doing a 45-minute procedure. And Foley is not the only catheter available.
The way to answer this is a very typical question. And if you know your theory, then you will be able to answer that question. What Mohan asked, how will you do a renogram in a child? Isn't that the question, Mohan?
Yeah, absolutely.
Yes. So they are very specific things, and it goes by a very particular name. And if you have not read it, then you won't know it. So you better go and read that.
Okay, sir.
Yeah. There's a whole article on that particular subject.
Okay, continue. Describe.
This is first static film shows there is appears a bony landmarks normal, sir, and there is a gross bowel loading also. And
Loading. Where is the loading? I can't see any loading. That's just dilatation of the bowel. It's full of gas. Fecal matter that much is acceptable. It's gas. Even the stomach is filled with gas. Maybe the child was anxious. And there was a lot of error.
Just a point to mention, when you are looking at bowel loading, look at the sigmoid, look at the distal colon. That is where the problem arises, because that is where the issues are related to voiding. Not in the transverse colon and stomach and all the rest of it.
okay, sir.
Yeah. And they measure the rectal diameter. That's the reason. You measure rectal, you don't measure the diameter of the transverse colon and all that when you want to do this. So rectal diameter is important because that's where the action is.
And the second film is a cystogram film. It is showing bladder neck competent. Bladder wall is.
No.
How do you say that it's competent if I see something here?
What is the starkest evidence that you see? Before you go into final points, just looking at it, what can you make out of the bladder?
That bladder wall is slightly irregular wall, sir.
Yeah,
Not smooth.
Its outline is irregular. We don't know the
Yes, sir.
of the mucosa. And is a bladder filling into a normal bladder contour, or is there something about the contour that is worrisome?
Look like normal contour only.
You sure?
Yes, sir.
Go and look up a few bladder films in normal individuals. Okay. Okay, then what else? What is the next stark thing which hits you? Looking at
VUR, sir. It's grade 3 VUR.
bladder, just look at the bladder.
Slight contrast seen in the.
Look at that arrow. Look at that arrow. See, when somebody tells you what is there in the bladder.
Yes, sir. That contrast slight looks like leaking through the bladder neck. Sir. Bladder neck is not competent.
No, you said you made a statement. Bladder neck is competent. That was your opening statement. Prabhu had objection to that.
No.
So look at that very carefully. Then tie it up with all the other things. Then tie it up with the symptomatology of this child. Child had voiding problems, isn't it?
Yes, sir.
You have to tie it up now. Voiding problems. Look at this bladder. Look at this VUR. Is it just an ordinary VUR, or is there something more about it? Look at this bladder. Look at the contour of the bladder. So many things are there.
And since there was a doubt about a duplex system, we also have to see whether the reflux is leading to contrast in all the calyces or whether it is selective to one part of the kidney.
It is drooping lily sign is in lower
Praveen, may I again request you to let Sambaji answer? Are you seeing all three calyxes?
No, sir. Lower
Calyx is not
is
seen,
not known.
right? About the ureter, anything about the ureter? Does it follow a normal path or is there something abnormal about the ureter?
Sir, yeah, ureter is dilated and tortuous, sir.
It is tortuous, right?
Yes,
And
sir.
is there anything else you see in the ureter?
Yeah, sir. Contrast is not seen in distal ureter.
There is an area in which contrast is not seen. Maybe incidental or there might be something there. Correct? Is the bladder base at the correct level or is the bladder base elevated?
Slightly elevated, sir.
It is elevated, right? Slightly significant, not significant, we'll decide. Right? On the left side, is there anything?
No, sir.
No. In the urethra, is there anything?
Some little contrast is seen, sir, in this one, prostatic urethra.
Well, let us say the child is completely continent. Why is this contrast seen?
There may be urgency or overactive bladder.
No, child is absolutely fine. There are no such complaints. Child does not complain of urgency frequency. Mother has not complained.
There may this MCU may done by this catheter technique, and this contrast may be leaking along the side of this catheter cell.
Yeah, that's one possibility. Or as the catheter is withdrawn, some contrast might have gone into the urethra and remained there when the film was taken. Okay. Now you will say that the bladder neck is incompetent with confidence if you can see the entire length of the urethra. Otherwise, these are other things you have to take into account. We will see in the other projections and let's see if we find something. How did they arrive at bladder capacity 100 ml?
The contrast they might have filled that much only. Contrast along with normal size.
It only indicates how much the bladder is filled. It doesn't say it's the bladder capacity.
There is a
better assessment of bladder capacity.
See, remember, MCU is an abnormal thing and a very painful experience for usually children. It is not a normal. Don't decide on any capacity or anything based on MCU. I agree, the findings in an adult may be different, but children are very, very, you try to put a catheter, they are very violent. So it has its plus points, it has minus points.
With respect to the bladder, what we note all the time is whether the bladder is adequately distended. And we found a nice globular bladder, contrast outlining the bladder completely, so it's adequately distended. From the adequate distension, now when the child is voiding, we have to look at what happens to the void. You said there was some contrast in the ureter. So would you like to comment anything more in this?
No, this.
Of course, see, you have to see whether the child is dribbling urine. Not being able to void is one thing. Associated with dribbling would indicate something to you. We will have to explain the contrast in the urethra. If the child was dribbling, that explains the contrast in the urethra. Otherwise, the contrast is unrelated to bladder empty. Get the point?
Yes, sir.
Yeah. Okay.
So one small clarification.
At the end, Praveen. At the end. Yeah.
So we have done MCU now. Of course, you don't have a widening film if you are interested.
Yes.
So what do you want to do?
Sir, now I want to look for this cystoscopy and procedure. I want to use.
What do you want to see? You already seen it in CT scan, you already seen in ICU.
So still we are in dilemma whether it is this ureterocele is there or not.
So what is your full diagnosis after both CT and ICU?
Right-sided viewers, viewers, grade 3 viewers.
So is that the complete diagnosis?
It can be due to right-sided viewer can be due to secondary obstruction to cause that. Whether
Why
it
do you
is
say secondary obstruction? Let's go back to the last film of the MCU. Anything to suggest obstruction here?
the filling defect something else.
No, the contrast is drained completely. And the contrast, if there was obstruction here, you would have found the contrast filling the so-called filling defect. Correct?
Yes, sir.
In a ureterocele, the ureterocele fills with urine.
Some defect is seen here.
You're just saying contrast is that.
This outline is not so continuous.
That you can say. Is it contributing to your diagnosis?
This can be a primary obstructive, primary megaureter with VR, sir.
So reflexive megaureter or obstructive megaureter or both? We still have this question, isn't it? Is there obstruction or no obstruction?
Yes, sir.
How do we resolve that? If we suspect obstruction to the kidney and upper tracts, what investigation do we do?
Functional study we can do, sir.
Sorry?
Functional study, sir.
What study?
Functional study means DTP or either EC radiogram we can do, sir.
Yeah, so you can do a drainage study using radionuclides. Would you not like to do that before you put in the cystoscope?
Yes, sir.
Have you done that?
No, sir. I think it has stopped at management.
You stopped at this. Okay. So once we do that, we will have a good idea of whether there is obstruction. We'll also have an idea about reflux. We can do a combined study of voiding as well as renal drainage, read about it, in what sequence and how. But fine, they have not done it. So you want to do a cystoscopy.
Yes.
What do you expect to find at cystoscopy? Let us say at cystoscopy you find both ureteric orifices are normally placed. The contour is normal. There is no bulge seen through the mucosa. And the urethra has been normal as you enter. What all abnormalities of the ureteric orifice are associated with reflux? What may you find in a child with reflux when you do cystoscopy?
So that ureteric orifice opening patulous and displaced laterally.
Always patulous. What are the different types of ureteric orifices, configurations and morphology?
It's cone-shaped, horseshoe-shaped.
Sorry? Cone, horseshoe, then? Have you heard of stadium?
Yes, sir. Stadium I heard.
Have you heard of golf?
Yes, sir.
These are the four, right? So,
Yes.
in reflux, what type do you expect? Or what type will tell you, yes, this is definitely reflux? Which type of orifice morphology?
Horseshoe, sir.
Horseshoe is what you see so often.
Don't know, sir.
Don't know. Oi. Go and read.
Yes.
What is the meaning of this cone shape, horseshoe shape, stadium shape, and golf hole? In terms of anatomy of the uretrovesical junction, what does that mean? Read all this, okay?
Yes, sir.
Important to know the anatomy and physiology of the uretrovesical junction,
Yes.
both from an obstruction point of view and from a reflex point of view.
Yes.
And certainly to understand reconstruction.
Yes.
If that's required. Any progress on this child?
The case from discourse.
No, this put somebody is here.
Priyanko?
Are they here?
Priyanko?
I think they're online, but not in both places.
Yeah. Find out Sambhaji.
Yes, sir.
Okay, yeah. Praveen, you wanted to ask something.
Image. The image there appears to be that the pelvic system is at L3 level. Appears to be lower pole calyces with the reflux, and also the
L3 level, why do you think it's lower pole on the right side?
And the direction of calyces is also towards infrolateral.
They are laterally facing.
And the ureter is not as much dilated as in the CT, and also in the lower ureter we can see an impression over the dilated ureter.
Dilatation. Wait. Dilatation can be variable. Correct?
But contrast density is lesser. It is not narrowing there. It is the contrast density in that dilated ureter is less. Maybe because of the impression from the another ureter.
Okay, so what do you feel it is?
This is the duplex with lower moiety reflux and upper moiety obstruction.
Upper moiety obstruction, lower moiety ureter. Yeah, lower moiety ureter in this is refluxing.
Yes, sir.
Is
Yes, sir.
there hydronephrosis?
Yes, sir.
See, on the right side, where do you expect the upper moiety to be?
At L1, L2 level.
Sorry?
At L1, L2 level, sir, little lower than the left side.
The lower moiety would be much lower, right?
Yes, sir.
This is where I would suggest to all of you, don't speculate. What you can say is some calyces are filled with contrast, other calyces are not seen. I will agree with you about this possibly being lower moiety ureter for one reason. And what is that reason?
Direction of
Anybody? There is one finding on the MCU which leads us to suspect this might be the lower moiety ureter.
Ureteric insertion is cranial.
Insertion. Praveen, you have to think a little before answering. Insertion can only be made out at cystoscopy.
The upper moiety is not.
Unless it is ectopic, in which case you can see it somewhere else. What in this pelvic configuration suggests that this could be the lower moiety pelvis?
So upper moiety is not visualized, and the moiety.
We don't know whether there is an upper moiety or this is the upper moiety.
The direction of calyx.
What direction of calyx?
Pelvic calyx.
What calyx?
Lower calyx and ureteric angle.
What about lower calyx?
Lower pole.
Lower pole calyx.
So he means drooping of the lower moiety, sir.
Drooping, lower moiety will be drooping because it is below the upper moiety. You guys have not seen a drooping lily. You're calling anything and everything drooping. There is one finding, one very typical finding to suggest it is lower calyx. lower moiety calyx. Look at the inferior most calyx. Where is it pointing?
So,
Downwards. Can it point downwards if there was anything below it?
no, sir.
No. So for that one reason, I agree this could be the lower moiety ureter that is delineated in the MCU. Point well made. We still not explained the opacity in the ureter.
Yes, sir. That looks like anteroposterior compression, sir, from the other component,
No,
other ureter.
can't say. Can't say. Maybe may not be. We have not seen it. Correct.
Yes, sir.
So, Sambhaji, what will we do now?
Sir, functional study, sir.
For what?
To rule out obstruction, sir. Yes.
Obstruction where? There is a reflux we are seeing.
No, lower also.
You see, what came up during the discussion was that this could be a duplex moiety. The lower moiety appears to be refluxing here on MCU. It's possible the upper moiety is not seen. So whatever we do next, we want to see the upper moiety and we want to see whether the upper moiety is draining well or not draining well. And we want to see if there is a lower moiety which is not visualized on the MCU because the ureter is normal.
Okay.
Get it?
Yes.
This is how you will have to put it.
Yes.
Let the examiner know that you are thinking of upper moiety, lower moiety, reflux, obstruction, and the possibility of a normal moiety. Prabhu, anything you would like to add?
No, sir. Send a question and hopefully that part will be answered.
Dr. Ganesh, anything?
So they are muted.
It's probably in the theater. Okay then, thank you. We'll catch up next week.
So, Mohan sir?
Coming in late.
Mohan sir?
Yeah.
Sir, I presented that CT urography, sir.
Yeah,
Did
I guess
I answer? Did I answer what you asked?